for any healthcare practice, any city, some of the most expensive real estate in that market is healthcare type real estate.
I believe it.
And so by pulling that out of our business model, it allows us to bring care in a very convenient way directly into the homes of our patients.
Thanks for tuning in to the Self-Funded with Spencer podcast. Let's go make healthcare better together.
Zunich, right? Or Zunich?
Zunich, just like
Zunich.
Munich in Germany, but Zunich. Yes.
Zunich. Okay,
Yeah.
so Jory Zunich, and you're the SVP of Growth and Partnerships?
That's right, yeah.
Awesome, man. Of Nice Healthcare.
Nice
We got to
Healthcare.
get that in there, too.
Yeah.
And I'll admit, every time I hear nice, I want to do the Borat, like, very nice. Yeah, sorry, but I just had to get that out there. But I have featured Nice many years ago on one of the earliest podcast episodes I've done, but super excited to revisit, learn more about the model. I'm hopefully better at being a podcast host than I was back then as well. I just want to refresh this because you guys have grown quite a bit, and you and I connected here recently to sit down and talk. So welcome to the podcast, man.
Thanks a lot.
Awesome.
Thanks a lot. I appreciate you having me.
So Jory, you know the drill. Before we get to know what you do and the value that you provide, we always like to know who you are a little bit first. So
Sure.
I'd love to get the Jory bio for about 10 minutes or so if you could tell us your story.
Yeah, for sure. Yeah, I got into this insurance space trying to get out of the insurance world.
Really?
Grew up in a family of insurance agents. My dad and brother have an insurance agency in Western North Dakota. Primarily a P&C shop, crop insurance, hail insurance, things along those lines. That's where I worked as a kid growing up in the summertime. And it was a really logical move for me to go back home, give that a try right out of college.
But you said you early on as a kid, you like probably didn't want to do that or wanted to do something else?
It was a great opportunity, right?
Yeah.
It's a good business, established business. My dad and brother just know a ton about it. Great people that I could learn from. And they ended up going back there in a small town in North Dakota, kind of right in the middle of the North Dakota oil boom.
Okay.
In the Bakken out there. So it was a great time to be in that like community from a growth standpoint. The area probably went from 12,000 people when I graduated high school to now 50 or 60,000 people. It's a completely different place, brand new schools, brand new airport. But in the time frame in which we lived there, it was growing so rapidly. Got married basically immediately out of college.
Did you meet your wife in college?
Yeah, we both ran track and cross country to Iowa State.
All right.
And she is in advertising. And so I moved her to this small town in North Dakota. And we both were just itching to be somewhere else, right? And she had aspirations in her career to work with some advertising agencies and things along those lines, which you can imagine isn't readily available in Western North Dakota.
Yeah. Well, so outside of the oil and maybe shale industry, what is North Dakota known for? I've got a buddy that's from Spearfish, North Dakota. Or South Dakota,
yeah.
excuse me. Yeah. But I've never been. I've heard it is beautiful, but I realize the weather also can be pretty bad in the winter.
Yeah.
So what else is kind of there?
So when everybody thinks of North Dakota, they think of Fargo, right?
Yeah.
I live 6 hours from Fargo, or lived in the northwestern corner. So basically a different state. About 30 miles out of Montana, about an hour out of Canada. Okay, so way up in the northwestern corner. It's a beautiful area. Agriculture is huge. Oil and gas is also big up there. But if you like the outdoors, great hunting, fishing, small communities, and a lot of business growth out there, right? With everything that's going on. So I grew up there. We get back there on a regular basis. I'll be seeing my parents here again this weekend, and so it's a great place. But ultimately, we decided we're going to make a move, and so I was saying, I'm getting out of insurance. I'm going to go into healthcare administration. Kind of shortly after the passing of the ACA. There was a great program at the University of Minnesota, MHA MBA program, that I got accepted into, and was going down that path, but had about a year before that program started, and ended up meeting two individuals who are doing some pretty interesting things in the direct primary care space.
Yeah.
As well as in the health plan space or TPA space. And so I started kind of working for both of them almost as interns, building a very early form of a direct primary care and in Minneapolis. It was called Primacare Direct.
Okay.
Which was, it's effectively a network or a cooperative of independent practices in the Twin Cities who were offering a form of direct primary care to employers.
And at that point, not really anybody else doing it, or not many entities trying to do that. Very early
not
stages.
Many, right? And so this was, I guess, what I would consider hybrid DPC, meaning that they had a DPC practice, but were also billing insurance and taking insurance for other patients, right?
Yeah.
So helping kind of get that program off the ground a bit, as well as working with a physician, Dr. Merlin Brown, who had an idea for a new type of health plan, focused on total price transparency of cash-based pricing. Providers can publish and post prices into a marketplace. They're in control of those prices, can change them every day if they want to. And members of this plan can see, shop, and compare those prices. This was 2012, way before any price transparency laws, right?
Yeah.
The No Surprises Act.
I mean, a really novel idea at the time. Obviously I'm familiar with like bundled surgical pricing, like out of Oklahoma Surgery Center as an example. But the idea of publishing your pricing for fee for service in a primary care setting is like really novel idea.
Yeah, that's right. Yeah, so we succeeded in getting most independent practices in Minneapolis to participate in this marketplace.
Really?
The challenge was getting any hospitals on board, right? And building a new health plan. We're working with brokers to attract employers. And we come into this spot that the brokers are saying, how many hospitals are in your network? And the hospitals are saying how many employers are in your network, right?
Chicken or the egg, right?
And we kind of kept stumbling on that, right? Because at the time, the hospital systems really were not playing ball with price transparency, right? So what we ended up doing is creating a new product called Amplify, which was taking that marketplace of direct contracts for all of these healthcare services, not just MRIs and surgeries, but also primary care, OBGYN, things along those lines, that if patients accessed care through us, that their employer paid 100% of the bill.
Okay.
And we built that program up at the time when I was there to about 6,000 employees in Minnesota and Wisconsin. And it was a really impactful thing. And kind of long story short, I got involved in those two organizations. And the opportunity came to make it a full-time thing at Solarte Health right before my program started for the MHA and MBA.
So did you go? Or
I said, let's do it.
Yeah.
And so I never went. No, I never did. Yeah. And I guess the rest is history. Spent about 5 or 6 years at Solarte Health. Cut my teeth on, building a TPA, getting our TPA license, setting up a back office partner, and then also building that Amplify program, right? From there, I ended up at 90 Degree Benefits, a subsidiary of Blue Cross Blue Shield of Alabama, a conglomerate of TPAs with probably membership of now over 1 million members.
Okay.
And that was a wonderful experience where I was able to be in an environment with about 13 TPAs and those leaders who've been doing this business for a very long time.
Yeah.
And it was fun to be able to help more employers and bring very innovative health plans involving RBP, narrow networks, direct contracting, DPC into market, right?
Well, that's the fun stuff. And I can say in my career, I've missed working for a TPA and I've missed working for a PBM, and not missed it like I wish I had. But I think those areas of the self-funded plan, I don't have the direct inside expertise like I might for stop loss or captives. Yeah. And I think the TPA especially is the quarterback of any health plan.
Yeah.
And so that kind of wish, at some point I would have gotten some of that. So now I have to learn it from you instead.
Yeah.
But I think the knowledge that you were able to acquire inside of there sort of tells you how to run the entire thing.
Yeah, that's right. You understand all of the pieces, right? The full shopping of stop loss, understanding the differences in PBM models, right? Case management, population health, doing analysis on different types of networks and things along those lines. And so I am at heart, a stop loss geek. That is what I really enjoyed about that job, is understanding that. And what I ended up eventually finding out is that all of my plans, whether it was a plan taking advantage a BUCA network or a regional network or an RBP plan, all of them operated best when I had a direct primary care option on the front end of the plan to act as that quarterback for that patient, where they could go there, get great care that was accessible, and not worry about utilizing that complicated underlying insurance.
Yep.
And I've known the founders of Nice Healthcare since 2012. In my Solarte days, we used to office out of the same co-working space, and had some mutual clients who I put on Nice Healthcare on the TPA side of things.
Yeah.
And one of those clients is TPAC Underwriters, who I'm very close with, said, "Hey, Jory, we appreciate this program. We're going to put you on this so you can try it out."
Oh, wow. Okay.
And we just had a conversation about personally experiencing a direct primary care. And I was working with employers all across the country, talking a lot about DPC, putting it into a lot of groups, but I myself hadn't experienced it. I'm young, I'm healthy, I'm on an HSA plan. I wasn't really super interested in paying something out of pocket if my employer wasn't participating in it, right? Hadn't had a physical in 5 years. I was fortunate enough to have TPAC add me on so I could access a Nice Healthcare when I was at 90-degree benefits. And I had a physical in 3 days after getting access. I've had a physical every year since. And at that point in time, I said, I really like this model. An opportunity popped up at Nice Healthcare to come onto their sales team. And I guess the rest is history from there. And that's
well, I love the fact that it's a kind of we joke sometimes hair club for men where Pareto, we're also a client of our own captive, right?
Yeah.
But so I had that same thought is I talk about DPC a lot in concept, and I do believe in the value that it can deliver a plan. But I've never personally experienced a DPC. So you and I were having the conversation off record about I signed up for a concierge doctor, which is kind of a blend of fee for service and DPC. But I wanted to know, okay, the access to my doctor via text or being able to call him. I literally spent an hour in his practice and sat down with him personally. Talking about my health history and what I want to do, and at this stage of my life, what are the things to be concerned about from a health perspective, so that I could have firsthand experience of what that experience would be like to communicate it outwardly. And I think it's a really good thing. If you get the opportunity to do that, you should know firsthand what you're talking about publicly, externally. If you only know it conceptually, then you lose a little bit of credibility.
Absolutely. Yeah.
And so I don't want to skip over. I want to give you a chance to get some shine for your college athletic endeavors. We were talking about your running experience. I think you said you're at Iowa State, right?
Yep, Iowa State, yeah.
So you were a distance runner, correct?
Yeah,
multiple different distances. Give me some of your best times, your best races, man. We'll get it on record and make a clip out of it for you. So you can show your kids one day.
Yeah, for sure. Well, at the rate that these college athletes are accelerating right now, my times are not too fancy, but mile 4:06 the several times. Probably my best time, 13:57 in the 5K.
That's crazy.
I had a great experience at Iowa State. Just made a ton of friends there. Met my wife, obviously.
She was a runner as well, or what?
What
was her race then?
800 was her main thing.
Okay.
Yeah.
Do you know her best time? Can we give her
2:06 in the 800?
2:06. Golly, man. I remember we had to run some 400s in college after. So they would always make us do the Cooper test, which is 2 miles and 12. And I would always get close. A couple sub 12s. Every once I'd be like 12:04 or whatever. But then one time our coach is like, "Oh, by the way, I'm still want you to run these 400s afterwards after you get a break." And we had to do like 400s, and each of them had to be under 60 seconds, like the whole team.
Wow.
And we're like, "Oh my God, nobody expected it." But I remember just hoofing, trying to get under 60. So for her to do that, basically two back to back at 60 seconds, that's astonishing pace.
Yeah, she's cooking for sure.
I can't even get a sub 6 minute mile anymore these days, man. So, but 42. So that's my excuse. But anyways, I just want to give you a chance to talk about that, because I feel like everybody in the healthcare industry at one point was some sort of like athlete, and maybe we didn't quite make it to pro levels or whatever. But I think it probably shapes our interest in the healthcare industry, whether consciously or subconsciously as well.
Yeah, for sure. Yeah. Being a college athlete ingrains a lot of tenacity, right? Just being able to stick with something for a long time, right? Going through being in high school athletics into college and being a D1 distance runner, is probably better than being a pro almost. I mean, just in terms of resources available to you, facilities, coaching, wait staff. And so, yeah, just had a wonderful time at Iowa State. It was great.
Awesome, man. Well, so let's enter into the realm of Nice Healthcare then. So you said you knew the founders. Were you, did you move to Minneapolis after college or?
Yeah. So when we decided that we weren't going to live in North Dakota, we kind of looked at a handful of cities. I've got a brother in Minnesota, had spent a fair amount of time in Minneapolis, and my wife is from Cedar Rapids, Iowa. And so we landed in Minneapolis to be kind of in between family per se. And we've been there since 2012, 2013.
Okay.
And we absolutely love it. Actually live in Minneapolis proper.
Yep.
It's just been a great place for us.
Well, I've been there a couple of times, and it was kind of fascinating to me that how there would be like these sort of sky bridges between buildings that you could go through. Yeah, because I was like, oh yeah, it's deathly cold outside, and nobody wants to walk across the outside across the street. So like all these bridges exist, or what do you call them?
Skyways.
Skyways. Yeah. So I was like, oh, okay, that makes sense because I'm from Texas, and we get cold, but we don't get Minneapolis level.
And all the restaurants are on the Skyway level. So you don't experience downtown Minneapolis without the Skyway as well, right? Because thousands of people walking in the Skyway, different lunch spots and things along those lines. So
that's cool, man. Cool. It's a different world for me, but I mean, it's relevant to this conversation, right? Because the origins of Nice is from that area of the country.
Yeah, that's
correct?
right.
Okay.
Yeah.
So when did you join Nice?
2022.
2022. Okay.
Yeah.
And so like your entrance, talk about the entrance, and then we'll get deep into what is Nice and everything that you guys do after that.
Sure. Yeah. So like I said, kind of transitioned out of that TPA space where I was working with broker partners around the country to be the architect of these plans, right? Putting all of the pieces together. And a role opened up at Nice Healthcare. I knew a lot of the team there. And like I said, had found that DPC was the right pillar to activate patients, give them access, and just make healthcare simpler and more accessible, right? Okay. And so came in as a VP of sales, and have just had a great experience. We've experienced great growth. We're in 12 states now, servicing over 750 employers, about 150,000 patients. And so we've quickly become one of the largest direct primary care entities out there, doing it at this scale, helping that scope of employers as well as patients.
Awesome.
Pareto Health is the largest benefits captive in the United States. With nearly 3,000 captive members, $1.3 billion of stop-loss premium in force, and almost 1 million covered lives, no other benefits captive comes close to Pareto Health's scale. But it's not just about the numbers. Pareto Health is a mission-driven organization, and that mission has two distinct parts. Number one, to make self-insurance simple and more accessible for small to mid-sized employers. And number two, to arm them with the most powerful cost management tools on the market. So if you're an employer frustrated with your healthcare outcomes, or you're a benefits consultant looking for an alternative to the status quo, it's time to consider Pareto Health. Pareto Health, where employers come to do self-insurance right, to do it easily, and to do it at scale.
So let's talk about kind of the pillars of what you guys do. The virtual direct primary care is a component. I know mental health is a component of it. There's a generic drug component of it as well. Mm-hmm. And then home visits, I think, are pretty fascinating.
Yeah.
But why don't we start on the virtual DPC piece first? Yeah.
Yeah, absolutely. So Nice Healthcare is a primary care clinic. And we specialize in virtual and in-home primary care.
Okay.
Our company also has a physical therapy practice as well as a mental health care practice. And our goal is to take our integrated care model and make healthcare affordable and accessible for as many people as we can. And ultimately, how we do that is through our form of the direct primary care. Our employees, as well as their benefit-eligible family members who have access to our clinic, gain access to virtual as well as in-home primary care, our virtual physical therapy practice, our virtual mental health care practice. We employ all of our clinical team.
Okay.
So
they're all W-2.
Yep, yeah. That's right. Yep. We own all of our technology and our apps. So you're getting a very consistent experience across primary care, PT, mental health care with that integrated care component, right? Where a primary care team is in the loop with the patient who's also in our physical therapy program or our mental health care program.
Okay. When I was saying most DPC, when I think DPC, or most people I would presume think brick and mortar kind of consistently. However, there's been virtual versions and everybody's familiar with the telehealth, right? So let's differentiate what you do versus telehealth. But sort of why did NICE sort of lean in really heavily to predominantly virtual care instead of building out clinics?
Yeah. Our CEO kind of has always said, that the problem with healthcare is the price, right? And our goal was to bring a model that was very affordable for employers to make accessible this model to their employees.
Okay.
And one of the big pieces of that is pulling out real estate from our business model. For any healthcare practice, any city, some of the most expensive real estate in that market is healthcare type real estate.
I believe it.
And so by pulling that out of our business model, it allows us to bring care in a very convenient way directly into the homes of our patients or at their place of work, anywhere within our service territory we serve in our 12 markets, okay? And if you look at DoorDash, or you look at Uber Eats or Instacart, all of these are services in which people pay more for the convenience of those services to come directly to them. In healthcare, we're doing it in a way that is very affordable for employers, but is bringing all of that convenience to our patients, right? We are taking away them driving to a clinic, them sitting in the waiting room, all to have a short appointment, right? Or if you've got kids, everybody's had those kids in that waiting room where don't touch that, sit down, please. All of that goes away underneath our model where we come to our patients. Our providers last year drove 400,000 miles. That's 16 times around the globe.
Jeez.
That's time that we saved our patients.
Yeah.
That they were able to be with their family, they were able to be at work, and to have that appointment come to them.
That's really interesting. And before we go down the realm of when is it indicated for a home visit, I want to sort of answer the skeptic that says, well, like virtual primary care, okay, well, why not telehealth instead? What's the difference, right? So why don't you differentiate those two?
Yeah, absolutely. And when you look at a typical virtual only option, right? The scope of care there is typically acute care needs.
Okay.
Cold, flu, rashes, things along those lines. And ultimately in virtual care, that's table stakes, right? We do that extremely well. Most virtual vendors do, but there's limitations there.
Okay.
Let's say that you're a patient and you have symptoms of a strep throat. That cannot always be diagnosed virtually. Sometimes that strep swab is needed, right? And very often it is needed. A typical virtual only vendor is going to say, I'm sorry, you're going to have to go to urgent care or schedule an appointment with your PCP to get that. And that puts someone into sitting in a waiting room, trying to get the appointment, that the appointment isn't available as soon as they want it to be. Ultimately pushing people right back into that system that can be pretty inconvenient for people. NICE Healthcare is different, right? We're going to follow that virtual appointment with a home visit and take care of that swab for you.
And is there continuity of care in that they're seeing the same physician, or is it in a pool of physicians? Tell me how that works.
Yep, that's always an option, right? So we have the ability for patients to schedule a first available, or they can always schedule with a provider that they've seen historically.
Okay. Well, then about the health or in-home health visit then. Give me an example of okay, we do need to have hands-on and we need to come to you. So what would be a circumstance that would happen?
Yeah, absolutely. So the strep example is one, right? Kind of threading that needle for giving access to those acute care needs in a more robust fashion, right? But also in a virtual setting through a virtual only vendor, if you say, hey, I'm out of a blood pressure med, or I want to get a physical. Those are things, again, where you're going to say, oh, I'm sorry, we can't help you with that. Then you're directed right back into that insurance-based system. And NICE Healthcare is different. that's where we can handle those annual physicals, child checkups. In addition to management of chronic conditions, we've got wonderful type 2 diabetic educators. We can manage hypertension, thyroid issues, things along those lines. But when you couple that up with our 550 drugs included in our clinic offering, our virtual physical therapy program, our virtual mental health care program, our labs, as well as imaging, that's where you're getting to about 70% of everyday health care for a typical person. And we're bringing that directly to the patient.
Yeah, I love that. And you said you can even do like in-home x-rays, right?
Yeah, that's right. X-rays and EKG as well.
So like, what does that look like? Is it like a rolling x-ray machine? Like I can't picture this.
Yeah, it's a mobile x-ray kind of unit that comes directly into the patient's home.
So I could see a circumstance where I rolled my ankle last night in an over 40 soccer league or something like that, right? And I'm like, it's swollen. I don't know if it's broken. So I do a virtual visit. Probably, obviously I'm on a screen share so you can see my ankle. It's a little swollen. Doctor goes, you know what? We probably ought to x-ray that just to be safe. Right. So bring in a mobile x-ray unit at that time, verify whether or not it's broken.
Yep.
Like I like that. And the fact that if I'm dealing with a swollen ankle that's hurting me, I don't have to go somewhere to have it x-rayed. I could still perhaps work during the day and then have somebody come to me, and then I have a much shorter window of time that I have to get that care.
Yep.
So there's a convenience of that's obviously very valuable.
Yeah, absolutely. And that's a great use case of the x-ray, right? We often hear about...
Well, knock on wood, I don't know how to use it for...
Usually it's someone's kid was at a soccer match or something along those lines, rolled that ankle. And, this is a great alternative to be able to, first off, know that you have that care accessible to you, but also avoid those unexpected costs for taking care of that at urgent care or an ortho urgent care.
Yeah, the all-encompassing predictable costs is one of the main components I love about any DPC model is that it now becomes predictable. And we won't get into exactly price points, but you want to ensure that the price point doesn't all of a sudden become cost prohibitive because you're spending more on a fixed cost basis than you would a fee for service.
Yep.
So there's a sweet spot in there, but knowing that you won't be nickel and dimed for every service, and there's not incentive to do so and overtest and overtreat as well. Like that on its surface is really compelling to me. So you mentioned about 70% of care. Before we get into the other things you do, what is not an application for a nice healthcare? Yeah,
absolutely. Like we said, most things that you would come to expect from a primary care clinic, we're bringing to the patient, right? Things in which we're not doing are like vaccinations, right? Vaccinations have a storage component, right? They need to be kept cold. Our mobile nature is a little bit different for that. As well as breast and pelvic exams are something that is not done in home just due to our provider safety as well as patient safety.
Yeah, certainly. Yeah, you have somebody coming into your home by themselves and doing one of those type of exams that are very sensitive in nature, right? Especially being a female, if you're home alone, like there's some element of danger and skepticism, right? So you said you guys were maybe exploring the possibility of doing that in future, but you'd have multiple people that would need to be present to ensure safety.
Yep, there's multiple avenues kind of eventually adding that through our care team or partnering with others as well.
Chronic health issues, surprise out-of-network medical bills, inflated medical and prescription drug prices. These issues cost self-insured employers hundreds of millions of dollars every year. Add to this the rising cost of care and potential for waste across the life of a claim, and it's clear that self-insured employers need innovative solutions that lower their health plan spend. At Valence, we've done just that, developed innovation that shifts the current paradigm. A complete and integrated ecosystem solution driven by data, one that manages and simplifies the complexity of medical claim costs. It is through analyzing millions of data points that we enable employers to realize and fuel cost-saving solutions. Valence experts come prepared from day one, targeting the fraction of claims that will drive the majority of health plan costs. That is how our team lives the Valence promise, engaging early and often for smarter, better, faster healthcare.
Yeah, and I'd imagine, of course, the really urgent things, right? I did break my ankle, and it's obviously broken. Of course, I'm not going to sit around and wait for somebody to come verify that. I'm going to go urgent care or ER in order to get it addressed now, right?
That's right. We typically say if your care can't wait a couple of hours, that's something in which, the emergency room or urgent care would be probably your best route.
Okay. Right? And what would you expect? Let's say I did have a virtual visit and it was indicated I do need a home visit as a follow-up.
Yeah.
Like, talk to me about the turnaround time. If it is something that can wait a few hours, but we can't wait a few weeks, right? Like, how quickly can you get somebody in the home?
Absolutely. Yeah. So we just went through our app
you showed me
down at coffee this morning. And so we were looking at a kind of availability. We were chatting at 8 a.m. I could have an appointment today at 10:30 virtually, right? Yeah. So we're typically seeing people in about a 24-hour window of when they need that care. About 70% of our care can be treated virtually, but if needed, that's when that home visit follows. And our scheduling allows that if it is an acute care need, that the in-person component of that visit is pretty promptly following.
Okay.
Right? If it's a physical or something along those lines, we're going to schedule that out a few days so that we can leave some room in our schedule for those acute care needs.
And to reiterate, there's no additional cost if an in-home visit happens.
Correct. Yep.
Okay, that's fascinating. So out of that, though, like I think you were mentioning to me, the status or sort of like training levels of the individuals that do come into the home would be like a nurse practitioner, correct?
Yep, that's
and
right.
or a physician's assistant.
Yep.
Okay. So why is it that level of care is appropriate for what you do versus an actual MD? Instead?
Yeah, absolutely. Our company was founded by a nurse practitioner. One of our co-founders and our chief operating officer is a nurse practitioner. And ultimately, in our country, we have a shortage of access to primary care, right? And kind of getting into our business model again of taking out the real estate component by also utilizing nurse practitioners and physician's assistants and allowing them to practice at the top of their licensure is a way in which we can keep things affordable for our employer clients and still bring a great level of care.
Yeah, I mean, it totally makes sense, right? Because what we're trying to do is strike the balance in value being delivered versus cost associated with that value if the goal is to lower the cost of healthcare, right? If the goal is to have a white glove, concierge, extreme level of service, and we don't really care about the cost, that's a different equation altogether, right? And so I think you guys are striking a very nice balance. The home visits is one of the most interesting hooks to me. It's like, well, I don't think I've ever had a home visit of a physician. And I have this like pictures of old, in my brain of movies where doctor with a leather bound suitcase walks in with a stethoscope and comes and visits the sick kid that's sick in bed. Like there's something like almost Americana to me about that.
Yeah, very much so. Yeah. And the consistency of care, right? Our providers who are doing our in-home care are servicing a market, right? Where you're also seeing a recognizable face, right? So my kids, I've got two boys, 5 and 7. Their expectation of accessing healthcare is in our living room. They are.
That's funny. That's all they know then.
That's basically all they know, right? So they've got Bluey on TV while the brother's getting a strep test or whatever it might be. We've had 0 tears. Our average time with a patient for that in-person care runs around 38 minutes, right? So a really nice allotment of time where our providers can slow down. Take great care of our patients, but also our patients are comfortable, right? And they're in their home in a comfortable setting that just creates a really great environment for taking care of patients.
That's cool, man. Well, so outside of that, then I know there's a lot of things that you do. So why do you expand beyond primary care? What's the premise behind adding additional services into the fold?
Sure. Well, anyone who knows health insurance, right, knows that certain things are mandated as preventive coverage, right? And kind of underneath the ACA. Basic screenings, vaccinations, colonoscopies, things along those lines. No such thing exists like that for physical therapy or for mental health care. Okay, so we want to be that front door access to physical therapy as well as mental health care. So if people are having issues, they've got a route in which they can access that care. I used our physical therapy program multiple times. The first time I used it, I was lifting weights, dropped a dumbbell funny, tweaked my wrist. And I had a physical therapy appointment in 3 days. I got that appointment. I'm on an HSA plan. I don't know how long I would have let that fester before I would have gone through insurance, taken time off of work, gone and sat in the waiting room and had those appointments. I got directly into physical therapy. And I think I had 4 visits over about a 6-week period. Found out that it really wasn't my wrist. I had some tightness kind of in my chest, kind of weak back. Went through exercises live with our physical therapist virtually. Got updated exercises throughout that 6 weeks. And I learned a ton about my body in that time frame, right? To the point that I was able to be in the gym, taking care of my issues that entire time. But also about 9 months later, I kind of hurt that wrist again. I already knew what to do.
Yep.
Like, what's the value of that to me as a patient, to be healthy, to be staying in the gym and understanding how my body works,
yep.
right? All of that being accessible without having to worry about the cost is hugely beneficial for patients in the physical therapy space, right?
Yeah, and let me talk about a sort of contrast there to give you an idea. So I had neck issue recently that was, I think it was probably somewhat tension related, maybe poor posture, sleeping, sitting at a desk, and it was causing some headaches. And so I had that a couple years in the past, went to a chiropractor, was able to get some relief through the manipulation and some tissue therapy and stuff like that. But ultimately, I think what helped this time is identifying rhomboids in the back were weak relative to the traps and the lats. Sure. And so we're doing a lot of very targeted exercises to strengthen the rhomboids relative to those. And I think that's actually what is substantiated most of the relief to these headaches and tension. That also cost me about $1,600 for 12 visits because it's cash-based pricing. It's not in network. So I had to pay an exorbitant amount of money in order to get that relief. Yeah. So how much relief could have been provided in a virtual setting through exercises and certain stretching, and then how much could I attribute to the actual physical manipulation? I won't know for sure, but I know it cost me $1,600 to do that.
Yeah,
right?
yeah. But if you have easy access to understand, our physical therapy team is going to help you make that choice, right? And understand, like, yes, you do need
an intelligent step in between, right? Like to say, was this even necessary or not? Or let's try the most the less invasive or the least invasive options first to see if you do get some relief. Yeah. Also, buying just a new pillow kind of helped as well. So it could have just been the damn pillow.
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans and allowing them to create an environment where we ensure that the benefit plans are being charged in a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
Mm-hmm. But anyway, so I love the fact that you're wrapping those things around, right? Because what I suspect you guys are trying to do is be as comprehensive as possible within the framework of what you're still trying to do. So that people go, well, wow, there's so much value being delivered in this thing. Of course, we're going to add this to our plan.
Yeah, for sure. And what we see with our patients is that a patient might come to us for an acute care need, but then also learn about our pharmacy program and say, I'm on a few maintenance drugs. Yeah. I'm paying a $30 copay every month for those drugs. Those drugs are often available at Nice Healthcare. Our pharmacy program includes about 50 to 80% of the top drugs by volume on a health plan, right? Okay. Those drugs are included at no cost to our patients if it's prescribed at Nice Healthcare.
So generics, I presume. Are there any brand drugs?
It's largely a generic drug class, about 400 maintenance medications and about 100 acute drugs.
So what is the process then? If, let's say, I'm getting these prescriptions outside of Nice, I found out I can get them through this program at no cost for me. How do I switch it over? How do you guys do it?
You just establish care at Nice Healthcare, have an appointment with our primary care team, and then they'll make an assessment of the prescriptions, make sure everything is medically necessary and that they agree with kind of what's going on kind of in those scripts, and then ultimately write a script from there.
So the logistics, though, that's what I'm curious about too. Like, is it mail order then? Does it go through your own pharmacy? How does that work?
Yeah, so we have a network of about 60,000 pharmacies. People can pick up their prescriptions. We also have a mail order program for 90-day fills. On maintenance meds. In certain markets, we have partnerships with digital pharmacies who do in-home delivery of scripts as well.
Okay.
But it's all just rolled into our drug program that's included in our model.
Well, I like it, man. And I mean, that's the end of the day, right? We're talking about fair margin, and I don't know how you guys leverage economies of scale to do that, and if it's just pass-through pricing. But if me as a member going, Okay, get a virtual visit with the doctor. It's really seamless. It's through an app. A nice, obviously, 38-minute average visit or whatever the number was you said. Oh, and by the way, did you know you can now fill your prescriptions through us as well, and it doesn't cost you any money? That entire equation was $0 to the member, and you have the entire continuity of care in that equation as well.
Yep, and then the cross-pollination of the access to the physical therapy, our mental health care programming, labs.
Yep.
That's where you can see that people can really find nice health care as their primary care home as well.
Well, so before we move on to mental health care labs, how do you guys do the labs?
Yep, our lab draws are done in-home. When we include over 35 labs that are your most common primary care panels, right? It's a lab draw done in-home, and the results then are sent through our app to the patient.
So you have your panel results stored in your app? And
very easy access to all of your medical records at Nice Healthcare through that app in a document section. So in a matter of minutes, I can pull up all of my previous details. And then our care coordination team can also share those details out to other clinics on a referral basis if any care is needed outside of our scope.
Well, and that's what we were talking about too. Care coordination is a huge component of this because DPC, any version of DPC is going to have a limited subset of services that can be provided before somebody has to go somewhere else.
Yeah.
And the challenge is getting them to intelligently be directed to somewhere else where we know what they're in network or we know what the cost is going to be. There isn't some referral incentive to send somebody down the hall because they get a cut of that or things like that. So how do we intelligently design care coordination through a NICE to ensure the person goes to the appropriate next location?
Yeah, absolutely. And we have, across 750 employers, we've got a lot of underlying insurances across those groups, right? And so one of the really cool elements of that time with the patient is that if we think someone needs a dermatologist or a cardiologist or something along those lines, patients actually have time in that visit to be able to pull up a provider, a PPO site or a directory to find options in their network, right? And then our provider team is going to have their own opinion, right? Of here's someone who we've worked with before out of this list of people, right?
Yeah.
Who we might suggest. But then our care coordination and the provider ultimately work together to send off the referral for those patients. We also have health plan partners who are doing things with narrow networks or direct contracts, which we can identify and help steer care to those high value sites that are also financially beneficial to the patient.
Yeah, I'm glad you went there because I know with your background too, you understand these things. So that's what I was really ultimately getting at is how do you layer on top a better plan design? If NICE was the foundation of a health plan, you layer on top direct contracts or a narrow network or a combination of that to ensure now we're getting maximum value out of the middle ground of the services that are provided in a healthcare journey. So you don't just send them willy-nilly, they're in network, but who knows what the contracted rate is for a knee surgery at this location with an Aetna or just use any carrier. You're completely blind at that point of what the cost is going to be. So a nice intelligent middle layer of those narrow networks seems to me on the surface kind of the best construct of those two things.
Absolutely. And what I think has been realized more and more in the last 5 years through brokers, through stop-loss carriers, through TPAs, through large carriers as well, is that care is best managed and directed through the primary care office, right? That's where people are used to going to care. And ultimately, primary care has always helped patients ultimately get to that next step, right? So if we can more thoughtfully help navigate that with the patient and our partners that are also working with those employers to get people to that site of care that is financially advantageous while also still getting great care, that's something that our team's happily to help support.
Yeah, and I was just telling you over coffee, I've sort of been fascinated with this idea of how do you construct the perfect health plan.
That's
and so
right.
I won't drag us down that path again, but if I think about when we get into conversations around the future of healthcare at the end of the show, like what would that look like, right? Like in a perfect world, if we could design a perfect health plan. But I want to go into the mental health side of the equation first. I told you I was sitting down with Sims Tillerson yesterday, and I think we're going to break his podcast most likely up into 2 episodes, because the first one was his new consulting, Tillerson's consulting group.
Yeah.
And then we got into another basically back half of the podcast all around mental health. And so I would love to hear what you guys are doing to help solve some of the issues we're seeing with mental health care.
Yeah,
today.
absolutely. Yeah, such a large topic right now for employers, right? Accessing mental health care is really challenging, right? We have a provider shortage in the U.S., and mental health care is a top tier issue for any broker or employer that you talk to, right? And so, very similar to our physical therapy program, our mental health care program wants to be that front door into mental health care, right? This is an opportunity to have a program that ultimately really, kind of in my mind, or for people who are listening to this podcast will understand, it sits kind of in between EAP and a traditional kind of long-term ongoing therapy.
Okay.
It's okay. This is a program.
So EAP would be the kind of the crisis intervention circumstances. And then you said the other end of the spectrum is what?
Is like long-term in-person therapy.
Okay, so I've been going to a therapist for years, right, on a particular cadence.
Yeah,
okay, so you guys are in this middle ground.
Yeah,
okay.
That's right. And so we are there to establish easy access and available access to mental health care if you're dealing with kind of initial symptoms of stress or anxiety, managing boundaries. You want to become more mindful, right? Things along those lines that are things that all of us can work on to improve our mental health, manage our stress, and things along those lines. That is a perfect inroad for our program and model. And ultimately, kind of in the way I like to explain it is that access to that long-term therapy is booked months and months out, right? And you have people who are seeking that care who want to keep that appointment available for them out of fear of losing it. And ultimately that creates a backlog in the system, right? Where the people who need care now can't access that care. Our model brings that availability to a lot of those patients so that they can access a shorter form of brief psychotherapy through our model and not worry about long wait times and the cost.
Yeah, you raised that over coffee, and I think that's a really interesting bug of the system, if you will, is that you're saying people want to continue and have their appointment and go to that appointment, whether or not they feel they necessarily might need it, for fear if I get off the calendar, how long is it going to be before I get back on?
That's right.
But what the downside of that, of course, is the limited access to somebody that needs to get on the calendar and can't now. And so you guys are sort of backfilling that accessibility problem that you're seeing. Okay, and so these are still virtual visits, correct?
Yeah.
Okay.
That's right. Virtual appointments on physical therapy as well as mental health care.
Okay, so there isn't the opportunity though for an in-person visit through NICE for mental health as well. Okay, and can you envision a world where there are additional services being added to NICE over time? Or do you think you guys have like the NICE core of what you're trying to do already?
One thing I think that our founding team has done such a great job on is that they've been laser focused on a really good product offering that we've proven to be very, very scalable, right? You'll be hard pressed to find another direct primary care clinic that's operating in 12 states and serving this many employers and this many patients. And I think that was very wise of them to focus on that product, make sure that it's scalable, make sure it works for our business. But we are constantly evaluating like additional features, additional partnerships to ultimately expand our impact on the total cost of care of healthcare.
Yeah, I love it. Well, let's move to the subject of employers, so the actual application, right? So
Sure.
I think we've sort of like towed around the subject of like, who is this for? What do I need to be self-funded? Do I need to be a certain group size, et cetera? So why don't we talk about kind of like, as we identify people that are listening, oh, I might have an employer in my book of business I'd like to do this for. Yeah. Who are that right persona of employer?
Yeah, and that's a beautiful thing, is that we work very broadly across industry, right? Kind of having over 750 employers, it's very broad at where this can be applicable, right? And I think that's some of the beauty of the model, is that we're taking some of these models of direct primary care with brick and mortar or concierge care, which can be, quite frankly, unattainable from a cost standpoint for a lot of employers who are already dealing with significant increases on their major medical health insurance, right? And so we're bringing in an ability to say, hey, this is a great way to enhance employee benefits. Everybody knows the importance of getting people engaged in primary care for that long-term kind of understanding of getting people screened sooner, understanding what's going on with their health, et cetera. And so what we can do for employers is allow them to impact the claims of tomorrow, right? If a service happens at Nice Healthcare, it's not a claim on your underlying health insurance plan, right? So it's keeping those claims down, controlling those premium increases on fully insured or self-funded. And in doing that, that's a way that employers can actually have a new product offering that is making an impact to total cost of care, but also dramatically increasing access and the convenience of accessing that care.
Yeah.
Having spent years working alongside healthcare leaders, brokers, and employers, I know how overwhelming healthcare can feel for our customers. We've all been there. Those renewal conversations that never seem to get easier. Rising pharmacy costs and medical costs, and no real transparency into where healthcare dollars are going. That's why I'm excited about Nomi Health. They're not just fixing the old system. They've rebuilt self-funded benefits from the ground up. With Nomi's network, you can offer something truly different. No copays, no deductibles, zero out-of-pocket costs when members see a provider. It's the kind of benefit that makes everyone ask, why hasn't healthcare always worked this way? Ready to bring your clients something different? Visit nomihealth.com and see how Nomi is rebuilding healthcare, one employer and one community at a time.
And so they don't have to be self-funded, is what I just heard you say. Okay, so like in the realm of a fully insured plan, how do you fold into an existing health insurance plan?
Yeah, so I mean, we've got a variety of groups, right, who are either large group fully insured, or small group, and there's a variation of how they look at that, right? If they are underwritten, that claims basis is an important one, right? Of understanding what the impact is to a total claims, and then in the smaller groups, sometimes it's just a CEO or an owner of a business seeing themselves as a patient, like, and saying, hey, I've stretched my out of pocket about as far as I can to control these premiums. I know the type of care that I get from my family every year, and I spend X on it as a patient out of pocket because of my exposure on my health plan. A lot of that care can happen at Nice Healthcare at no cost to me. And so being able to think about accessing care not only as a employer making an HR choice of what the benefits are, but viewing yourself as that patient and realizing, okay, this makes sense for me personally. I see that application for my employees as well.
So I'll use a pun. Are there any health plans that you guys don't fit nicely into their ecosystem, where they don't sort of allow you guys to coexist with their fee-for-service primary care, or is that never been an issue?
No issue there.
Okay.
We've got employers with HMO offerings. We have kind of a traditional PPO plans, RBP plans. We've got the gamut of plan types underneath.
Is there any limitations then on group size though, or does that really matter either, as long as they're in your states of service?
Our model's in 12 states currently. Our minimum employer size is 10. So we are very accessible for a multitude of employers. an opportunity in Washington is coming on 7/1 with over 12,000 employees, 600 employers.
Okay.
And so we can service at large scale as well, and kind of continue to go up market while also taking care of those small to medium
and so
businesses.
I think that leads me to the next conversation is like, I know obviously you guys want it to be accessible to all, right? That's the goal long term. Right now we have 12 of the sort of 50, states in the United States. So what does it take to stand up a new market? Like, what are the challenges? How many boots on the ground, licensing? Like, let's talk about that.
Yeah, absolutely. So currently in 12 states. We're currently assessing several additional markets in which we're moving into. We ultimately work with our broker partners and employers that are interested in our model, have experienced our model. Someone who's acquired a company who had our services in another state. That puts us in a situation where we evaluate markets based off of those opportunities, right? So we work with broker partners to say, okay, first off, understand our model and if it is a fit in your market and with your employer populations. And then we have kind of initial conversations to evaluate that market, what our footprint would be, and have employer conversations and say, hey, if we come into your market, are you interested in this model? And we kind of continually expand.
Yeah, and is there sort of like a critical mass of lives that would be required to open up a state?
Yeah, it varies by market, right?
Okay.
If we're expanding in to a new market in a state that we're already servicing, that number can be a few hundred employees, right? But launching in to other brand new states and things along those lines, we're getting to kind of a critical mass, but it's a case-by-case basis in terms of what that looks like.
Cool. So, well, and I'd love to see it proliferate across the country. I'm sure, obviously, if you just go to the NICE website, you can see the number of states you're in as well.
Absolutely.
And also, encourage folks that are listening to this and, want to reach out to have a conversation. Is this accessible in my state? If not, what would it look like for me to be able to help you stand up this new state? What would be the typical timeline then? Let's say there was critical mass of lives, you have interest in that state. Like, how long of a time frame would somebody need to be able to do that with you?
Yeah. Every state is a little bit different, right? With licensure and timing of getting clinics licensed and providers licensed and things along those lines. But you're typically looking at a 3 to 9 month window, in terms of getting things lined up.
Sure, like let's have a 1-1 conversation now. Now it won't be when it's released, but now March, it's probably a good time to start these conversations. But hopefully, it's already set up, right? And so then it's pretty turnkey. Yeah. Is this something that's typically done on cycle for effective dates, or can you do it off cycle?
It can be done off cycle as well. We have a lot of employer groups who actually prefer doing it off cycle to really hone that conversation around NICE Healthcare and this new offering, to not be bogged down with all of the other benefits conversations. And that's where our client success team at NICE Healthcare does a wonderful job ultimately engaging these employers as well as their employees. We keep about 90% of our clients every year. Mm-hmm. And so our retention is very, very high. Our patient NPS score is 92%.
Okay.
Outstanding in the healthcare space. Yeah. Outstanding even if you look at other industries like Netflix, Starbucks, Amazon.com. You're talking about NPS scores in the 70s, right? And our team's doing that at 92% in healthcare.
Yeah.
Right. And so that ability to ultimately educate those people on what our program offering can be done on cycle or off cycle.
Okay. Well, and so last question before we get into kind of zoom out and big picture of healthcare and end the episode. Utilization is going to be a big part of the conversation, right? Mm-hmm. So I'm spending X amount of dollars in fixed costs each month for access to NICE Healthcare. Equate that to me, and what is the targeted utilization and why, I should look for a certain amount of, but not, I shouldn't presume 100% are going to be using every single month. Otherwise I got super sick people.
Sure.
So what is an appropriate target for utilization on this?
Yeah, absolutely. We see that our utilization is over 3 times higher compared to a virtual only healthcare offering.
Okay.
Right. And so we're engaging a very large percentage of the population who needed care on a monthly basis. Right. And so For us, like we look at our total rate of utilization, largely by how many visits are occurring, by how many employees are on the program, right? And so we kind of target 9% as our benchmark type of rate of utilization. Our average across our block of business well exceeds that. And so what we've found is that our utilization rates across all of our groups, based off of group size and by tenure at Nice Healthcare over a 4-year window, is very, very consistent. And that's what's been really beautiful about this model, is that can you engage a 2,500 employee group like you can a 10-person group, and we've proven to do that very, very consistently across all.
Yeah, and so, without proper context, you gave the relative nature of your utilization versus typical primary care, somewhere around 3x. And is that looking at members or is that just employees? Because you guys do cover direct dependents on the plan as well, right?
That's right. So our model includes the employee as well as the benefit-eligible family members, and so those visits can be driven across that population.
Yeah, because I'm just thinking about my use case. My wife and kids go to some sort of doctor more often than I do as a stubborn middle-aged man. But let's go into the big picture of healthcare stuff and just kind of finish off the podcast. I really appreciate you coming down and doing this. I always like to ask the question of where do we think the next couple of years of healthcare are going, right? Like you guys obviously have a clear picture of what you're accomplishing in the realm of primary care and physical therapy and mental health. But if we think the whole picture, right?
Yeah.
What do you think? You've been here in this industry a long time. What are some big changes or things that we're going to have to deal with in the next couple of years that you think?
Yeah, I think I kind of alluded to it earlier, but I think we'll continue to see primary care be the basis for all success for employers getting their hands around the total cost of care, right? We've found ourselves in a situation where almost every broker I meet with is feeling as though they have their employers stretched about as far as they can from an out-of-pocket standpoint, and they're running out of real estate to control those premiums, right?
Yep.
And that's why we're seeing it's a trend into even more self-funding in smaller group sizes and things along those lines. And ultimately what they're reaching for is trying to get their hands around this large expense in their business, right? And doing that in a way that doesn't have easy access to primary care isn't always the best patient experience, right? These health plans can become very complicated, right? We've talked about a TPA being the quarterback of all of these pieces, but they're ultimately managing so many elements that are independent companies. Those are separate phone calls of the TPA can't solve this problem because it's a vendor that needs to solve that problem. And all of that can just slow things down for the patient, right? And so I think we'll continue to see more and more innovation around incorporating primary care into those underlying plans and increasing that impact that you can see across total cost of care by adding more services and things.
Well, and I really appreciate the way that you describe that, because when I talk about positioning the idea of self-funding to employers who are fully insured today, one of the things I really clearly highlight is the disentangling of claims from insurance, right? So if they're in a fully insured model today, insurance is 100% of their spend. When you separate it and become self-funded, now maybe 60 or 70% of your spend is actually claims themselves, right? So you're taking that out of the insurance equation. You're purchasing stop loss for catastrophic events, but you're more efficiently paying for claims that fall underneath that through cash. Now you guys are taking it a second layer, the way that I think about it. Let's disentangle primary care away from fee-for-service or insurance billing altogether as well, and let's turn that into a capitated or a fixed rate, but then add a lot of value in that layer. So it's sort of further breaking apart the pieces of what we think a health plan are to make those components more efficient. And that's what I think. The more employers understand that, the more we can sort of start to solve these problems, because it's not hidden or folded into premium that obfuscates my spend, and I have no idea where my spend is going. So soapbox moment for me, if you will. But
absolutely.
I think That's the way we need to start intelligently thinking about these things, is breaking apart the pieces that are trapped inside of insurance and then appropriately deciding which one apply to insurance and which one should be a fixed cost instead.
Yeah, absolutely. And there's just...
Make that a clip, Nathan. Thank you.
And there's, there's great things happening like in that space, right? I was just on a call talking to Rightwise, talking about what they're doing by trying to capitate the risk of pharmacy and capping trend there. These are solutions that are going to be really, really important to try to get our hands around that total cost.
Is Rightwise, is that Hari?
Yeah.
That's what I thought. Yeah. I got to sit down and catch up with him on that.
Yeah.
But, all right, man. So, Jory, why don't we do this last question? My favorite question is, I want you to summarize the whole episode in 1 or 2 sentences, but just your closing thoughts, right? I'd love for folks that have listened to this or compelled by what you're talking about, if you want them to have a takeaway or 2 from the whole episode, what do you think that would be?
Sure. Yeah. Takeaway on Nice Healthcare, I think, is that by being able to think about things differently, right? When we kind of a segue off of kind of all of your conversations around, can we break out these pieces and look at making those individual pieces can work well at a price point that makes sense for employers at scale. And I think that's what Nice Healthcare has done on the primary care side of things, right? Is that we've proven now, being in business since 2017, that this is a model that increases access to care in a way that patients have not yet experienced, right? People are accustomed to thinking that it takes a long time to get an appointment, that they're going to have to sit in a waiting room, and have an unknown bill at the end of the day, right? They are now experiencing at Nice Healthcare having complete access to primary care, physical therapy, our mental health care programming, our prescription drug programming, labs, imaging, all at no cost to them, ultimately while also bringing it into the comfort of their homes, right? And doing that is a way in which we are getting our hands around our portion of the total cost of care, which has been really, really impactful for our employer clients around the country.
Awesome, man. Well, I could just say very nice, to close the loop on that.
Yeah, you cannot get out of a Nice Healthcare conversation without some puns, so I appreciate it.
Oh, so I'm not the first one that's ever made that association? Damn it. Okay, awesome. Well, Jory, I appreciate you, man. This has been a lot of fun. Thanks for connecting and coming down here. I wish you safe travels home. And in maybe 2 to 3 years, we'll do an update on Nice Healthcare, and you'll be in 40 states.
That sounds great.
Awesome, man. Appreciate you.
Yeah, thank you very much.